Improve posture with top-down mechanisms. Stay tuned because today you will discover the importance of coronal and sagittal balance, gait, and mobility for your patients. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions to get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. J. Hartley has a unique perspective on scoliosis, having it himself. His practice has focused on scoliosis for the last 10 years. He's a graduate of the Palmer College of Chiropractic, a board-certified chiropractic neurologist, a fellow of the Palmer Academy of Chiropractic, and a fellow of the Clear Scoliosis Institute. Today he'll be sharing with us Posture-Neurological Predictor to Gait, Movement, and Mobility. Dr. Hartley, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please take it away.
All right, today I'm going to be talking about posture, neurological predictor to gait, movement, and mobility. And Krista already talked about some of my credentials. And we're going to be reviewing the importance of coronal balance and gait, importance of sagittal balance, motion and mobility, mirror image exercise with dynamic challenge positions, coupled motion amnesia and the homunculus, vibration therapy in the cerebellum, accelerating motion pattern recovery. There's plenty of research out there, and I'm just putting a few articles for you guys to use as a reference, and which includes some diagrams that are part of some of those articles. But when I saw Dr. Burns's topic from a neurological and posture standpoint, everything we do is really running through the cerebellum and the basal ganglia. And when those are working properly, usually people have proper motion and gait. And many years ago, I had seen Dr. Dan Murphy talk, multiple times with chiropractic biophysics, and he would always tell us, when you're at the mall, look at people that are walking around. Those that have poor sagittal balance are usually walking slower than those that do not. And so you can just see how everything runs through the cerebellum, and the cerebellum has more neurons in it than any structure in the body, and it's also very oxygen sensitive, which relates to chiropractic with the upper cervical spine and breathing pathways. So the importance of coronal balance, it's associated with abnormal gait, hip, knee, ankle, and foot pain, brain hemisphericity, cerebellar dysfunction, eye movement dysfunction, and unbalanced scoliosis. So we're going to run through a couple of our patients here. And Anne, you can see, had very bad coronal balance, and she also had abnormal gait, knee pain, and hip pain. By focusing on her posture, her mobility increases, hip pain, knee pain decreases, and gait gets better. We recommend that if you see an abnormal gait, to do a video of the patient, or if you have an abnormal neurological finding, because that's the only way you can really do a pre and post. And, that may be with some of your cerebellar testing, reflexes, anything that's positive. If you video it, that's your pre and post evidence. So this is her improvement of her nasium x-ray. This is not weighted. This is just her seated pedibond nasium x-ray before and after, with mainly focusing on a brain-based postural rehab. And then in her brace, which we use Scoli brace as part of our coronal balance correction, her scoliosis goes from 63 degrees to 34 degrees in the brace. And you can see the dramatic improvement of the coronal balance, which then is going to relate to less stress on the hips and knees, creating a more fluid gait. This patient, although he did have some pain, this posture he has was a chronic posture that he had for many years. This isn't like an acute antalgia. This was just his posture. And this quote that's on there, was a phone message he left me. I called to check on him, how he did after the first visit, and this was an excerpt from the after the first visit. So you can see how much better his posture is. That's after 33 days, and he was able to walk and move without pain, with great postural, without any specific extremity work. It was just correcting his coronal balance. This patient has Parkinson's disease. You'll notice the wide gait she has, as well as the coronal abnormal posture. And then on the follow-up x-ray, without us prompting her. So when you're looking at this cerebellar function in the AP posture, you just take the picture and then notice the gait. And then the same thing on the follow-up. We didn't tell her to put her feet back together. She just did that naturally as her cerebellum was functioning better. And she went from really struggling to walk around the office to really having fluid motion with her ability to walk. This patient was more initially of an acute lower back. He came crawling in on all four legs, on all fours, and had a dramatic correction, back to playing golf, improved gait, and that's his x-ray correction. The sagittal balance, we talk about a lot in the scoliosis world. You can't always correct a coronal balance or a scoliosis, especially when you're dealing with older adults, but you usually can improve the sagittal balance. And poor sagittal balance is directly related to disability, falls, fractures, cerebellar ataxia and a wide gait, loss of cerebellar function. So it's a true window to how that cerebellums work. And CVP just put out a paper in the last month about forward head posture and how many things you can relate to from a functional standpoint, and it's very true. And so you can see the patient Anne had very severe anterior head translation, greatly improved, and you can see with the scoliosis brace on how her sagittal balance is very improved. This is the Parkinson's disease patient. Again, you can see great improvement in her sagittal balance. And then she was the same one that had the gait improvement in the wide stance gait improvement. This patient had severe anterior head translation. She gained 1.5 inches of height in her care, and that's something that we will see in postural correction. So if you correct the coronal and sagittal balance, many times in older patients, you will see them improve. Her head was so far forward, we couldn't even get a true nasium x-ray when she first started. And now when we take a nasium x-ray, there's no issue. But if you look at the initial posture picture, if you look at her chin, notice how low it is on her chest. And then if you look at the follow-up, look how the chin is elevated over the chest. So the neurological implications with that are huge, but we know that our basal ganglia, or cerebellum, the brainstem is working better when we see that improved posture. Mirror image exercise with dynamic challenges. So imagine, if you're familiar with CVP, you're doing a mirror image of their posture or their x-ray finding, and then at the same time, you will have them do extremity exercises which may be interfering with their gait. So let's say they have a weak psoas on one side, or a toe drop or something like that. We will have them do the exercise for that extremity motion at the same time they do the mirror image exercise. And so they're holding the corrected posture, and then they exercise the extremity that's weak, and it creates more of a global correction. And then if you do pre and post gait videos, you'll be able to determine your success. Coupled motion amnesia and homunculus. So what we're talking about here is when you have neurological dysfunction in a joint, the appreciated area in the brain becomes absent in a way. And so when you do the adjustment, you can actually work those pathways. So if you do a coupled adjustment in the extremity of the extremity that's not functioning properly, so let's say we're working with the shoulder. We do a coupled adjustment on the shoulder, then we do a couple adjustment on C5 if we found that that's appropriate with our exam and x-ray, and then we do the mirror image postural correction while they're exercising that same extremity. And then as the appreciation of that area returns in the homunculus, we can expect to see improved gait and movement. If you're unable to achieve normal motion, then you can use a mirror box or dress mirror. So that's the homunculus. And in the neurology program, Dr. Carrig would talk about this quite a bit. And if you can visualize things, why somebody loses function, sensory or motor, it can be very helpful. So the mirror box is they're putting the impaired extremity behind the mirror, and then they're looking at the mirror at the good extremity. And then when you do normal motion with the good extremity, it actually wires the brain to get the pathways going to the poor extremity working correctly. And when you look at a gait patient, if they've had some kind of surgery where they can't use that, or if they've had some kind of paralysis, their brain doesn't think they can do it. And when you do those mirror exercises, it actually creates that pathway, even though they're not moving the affected extremity. And it can be helpful in those patients that when you're examining them, they don't restore to normal motion after their adjustment. The vibration therapy and cerebellum accelerating motion pattern recovery. So we use a vibration platform at 30 to 50 hertz. We will have the patient on an unstable surface, so either a vestibular pad, air disc, depending how high their cerebellar function is. So if they're functioning very poorly, like that patient Ann we showed you in the beginning, she may just be on the vibration platform. And then the next step up would be a foam pad. Next step up would be the air disc. And that challenge creates that writing reflex that Dr. Pettibon used to talk about, which assists in the correction. Then we will use spinal weighting. In spinal weighting, the simplest way to understand it is you weight in the direction that makes the posture worse, and then the body responds to that, making a correction. You confirm that with photos of the posture and x-ray to make sure that it's working correctly. Never assume that a head weight is correcting something correctly. If they have a neurological problem or segmental stability, they may actually look worse on the x-ray with the head weight, even though the posture looks better. So you want to always take a stress x-ray. We have the patient do eye exercises while they're doing this. So if we don't have a specific neurological finding in their eye motion, we will just have them do a word search while they're doing this at the same time. So we're getting the mesencephalon to kind of piggyback into that pathway, and I'll show you that in a second. Or if they have a specific eye dysfunction neurologically, we'll have them do a specific exercise for that. You can also have them do the extremity motion at the same time. And then you're going to continue working it to tolerance to create neuroplasticity. You want to do a pre check, challenge check. So while they're doing the exercise, you're looking at them, and then a post check. If you see that they're failing during the exercise, then you want to stop that and then maybe go back and do it the next time with a pulse ox so you can help to predict whether they're going to fail or not. This is an example of a patient, the sagittal view on an air disc. She has a combination of the weighting called a hood and anterior chest weight and an anterior lumbar weight, helps bring the head back over the shoulders, lower cervical curve in, and the lumbar lordosis in, balancing on the air disc. She's doing the word search. And then this patient also has a left lumbar right thoracic scoliosis. So she's raising the left shoulder to reduce the right thoracic scoliosis. And then the lever arm she's using is called a hip lever arm, and it's reducing the left lumbar scoliosis. Now, in this patient, when we took the stress x-ray, she had a 100% reduction of her scoliosis. So we're feeling pretty good about this exercise for her. And you always want to do stress x-rays because you don't know whether it's making it better or not without the stress x-ray. And like we said, there's a lot of stuff out there that relates to what we talk about. Vestibular perceptual learning improves self-motion perception, posture, gait in older adults. So this relates to the homunculus and the gait patterns that we talked about. You can see the mesencephalon and how it piggybacks into the brainstem in these pathways through the cerebellum. So we're just using that as a tool to accelerate things with the correction. So in summary, you want to do an initial neuro exam with video of positives, posture photos, gait video, initial x-rays. We do the Pedibond series, flexion extension, ALR x-rays, P-Day scoliosis, brain-based and subluxation reduction adjustment, restore posture, spinal and extremity coupled motion. Challenge exercises with confirmed correction during and post, confirm during exercise improvements or fatigability. If they're getting in pain or fatiguing, posture gets worse, you want to stop the exercise for that session. If neurotest, posture or extremity motion worsen, then consider a reassessment. Use a pulse ox to, in the future, to gauge the fatigability. So the pulse ox, if you see the oxygen saturation go down or the pulse go up, then that tells you that's the time to stop the exercise. Then we're going to do a post neuro exam with video of past positives, posture photos, and gait video. And you'll never be able to have a pre and post video if you don't do the first video. So it's a good habit to get into.
All right,
Okay.
Dr. Hartley, thank you so much for your excellent presentation. I'm going to go through a summary and then a couple of questions for you. So you talked about from a neurologic standpoint, when it comes to proper gait, motion, and movement, it really comes down to the cerebellum and basal ganglia. And poor sagittal balance, people tend to walk slower. With the cerebellum, it has more neurons than any other organ in the body. It's highly oxygen sensitive. With the coronal imbalance, it's associated with abnormal gait, brain hemisphericity, eye movement dysfunction, and scoliosis. With abnormal gait, we always want to perform pre and post videos. And like you mentioned, if you don't perform the before video, you can't compare an after. You talked about the Scully brace for coronal balance correction. And then with sagittal balance, motion, and mobility, looking at sagittal imbalances, which can create increased disability, falls and fractures, cerebellar ataxia, and is associated with loss of cerebellar function. You talked about the importance of mirror image exercise with dynamic challenges. So mirror the posture position, maintain overcorrected posture, perform extremity motion, and then repeat the extremity motion while doing the mirror image exercise, and hold the corrected posture and exercise the weak extremity. And then you talked about coupled motion amnesia in the homunculus. So the neurological dysfunction of a joint leads to disuse, which creates a loss of appreciation of the related area of the brain homunculus. Sensory loss reduces motor output, created a downward spinal wind up of loss of sensation, weakness resulting in abnormal coupling and abnormal gait. So this can become a chronic pattern for your patients over time. You talked about mirror box therapy, so putting the impaired extremity within the box, watching the good extremity in the mirror for homunculus activation. It creates the pathway even without moving the affected extremity. And then vibration therapy and the cerebellum accelerating motion pattern recovery. So 30 to 50 hertz of vibration platform, vestibular pattern air disc to tolerance, so putting that on the vibratory platform, spinal weight or lever arm based on posture and x-ray, eye exercises to engage mesencephalon, for example, doing a word search, repeat normal extremity motion, continue to tolerance to create neuroplasticity, do pre-checks, challenge checks, and then post-checks. And if we see that the patient's failing during the exercise, I love this idea of stopping and reperforming with a pulse ox to gauge their level of fatigability. And then neuro test with video, the initial positive, do gait videos, do photos, as well as x-rays. And then vestibular perceptual learning improves self-motion, perception, posture, and gait. Really great clinical takeaways. Thank you again, Dr. Hartley. Couple of questions for you. Regarding retesting and re-imaging, with a scoliosis patient as our example, how often are you doing re-X-ray and redoing posture images and redoing gait videos?
We're usually doing that every 12 visits. And then we will do scoliometer, which is like a level that you roll on the patient, and posture analysis more often, like if we're trying to figure out the proper therapy for them.
Uh-huh.
In the scoliosis world, if it's an adolescent patient, there's urgency to get things right because we might be trying to get a person below surgical threshold.
Mhm.
So you take more x-rays than in a standard chiropractic office.
Sure.
And then in adults, we're still monitoring things. As you get older, you can have progressive scoliosis as well. So after menopause, and then when you get up to 60, 70, 80, you can have some dramatic changes in a short amount of time. The curves can progress as much as 3 to 6 degrees a year. So it's important to monitor. And we also want to see that the response to our care can change the listing. So we want to make sure we're updating that information.
Excellent. And can you tell us a little bit more about the hip lever that we saw in the image? How do you utilize that? And can you tell us how we would approach it with a patient?
Yeah. Now, this is a detailed type of care that we do. So the hip lever arm is something that is taught through the Clear Scoliosis Institute.
Mhm.
And if you think about like Dr. Pettibon taught in the beginning with the riding reflex. So if you have a forward head posture, you're putting the weight here. Initially, the body's going to fall forward, but then it's going to realize that's happening if you have a proper nervous system, and then it's going to make the correction. If you take that into the AP picture, okay, if you have a left lumbar curve, which is the patient that it was in the slideshow, if you put the lever arm, it has a strap that'll be just below the apex of the curve, and then the weight's out in space about 30 inches. The body will respond to that dropping weight and then reduce the left lumbar curve,
Gotcha.
similar to the anterior head translation, but now we're talking about a lever arm that's creating a fulcrum at the apex of the Cobb angle. So let's say if she had an L3 Cobb angle on the left, if the weight is over on the right, then that will hopefully reduce that curve. In her case, she had 100% reduction. And if you get a patient that's, pre-puberty,
Mhm.
it's much easier when patients start to get older, going through puberty and after puberty. If they have a large curve, you have the Hooter-Volkmann principle, which starts to deform the bones. It's a little more difficult, but you still want to reduce these as close to normal as you can, because you're preventing it from progressing later in life. And we know that people that have a scoliosis in adults, it may increase a degree or so every couple of years. But then when they get older after menopause and then 60, 70, 80, it can dramatically accelerate, and which is going to result in a lot of that dysfunction that we talked about with the disability, falls, fractures, all those things.
Absolutely. Yeah, thank you for sharing that. And then one final question for you. You talked about utilizing vibratory platforms and then combining that with things like X-rays as well as, or I'm sorry, not X-rays, combining that with the weights, the labor, as well as doing the exercises. When on the vibe plate, how long are those sessions that they're doing the vibration combined with the other therapies?
5 to 20 minutes would be the range. In Harrison's work, he'll talk about so many minutes required to make a change. The vibration accelerates that.
Mhm.
So if we're getting a good correction with 5 minutes on the vibe, some patients might do that. Others might do 20. And, it just depends on how we're doing with the correction. But 20 minutes creates a lot of neuroplasticity. It's kind of a threshold.
Excellent. Thank you. And as we wrap up another great session today in the Virtual Neurology Summit, I'd like to acknowledge Dr. Hartley for his excellent work in scoliosis correction. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.